All right, so we have a case. It's a 38-year-old female. She's coming into the clinic with blurred vision in the left eye for about 10 months. She didn't have insurance, so she hasn't received any kind of treatment for it, and she just recently got insurance, so she decided to be seen. She has a history of type 2 diabetes and hyperlipidemia. She's taking metformin, some multivitamins, and medicine for her hyperlipidemia. Vision in the right eye is good. Left eye, not so good. She's 2160 with no improvement on pinhole. Pressures are 16 and 15.
All right. Can you guys hear me?
Yes.
Yeah.
Perfect.
Okay. So media looks clear. Nerve, maybe mildly pallorous, like a 0.7 cup disc. Vessels look inferiorly looks a little stifled. Some of the vessels look a little stifled. Maybe a little bit of some sort of perivascular exudative material or something like that inferiorly, and also on the inferior mac, maybe some exudative material there as well, right around the vessels. And then very far superior, I don't know if that's artifact, there's like a little white spot about a quarter disc diameter.
I think this is mostly normal. I think you're overreading it.
All right.
Might be some little dot plots here too.
Yeah, maybe some spots of hemorrhage.
Okay, this one, media is a little bit more hazy. The nerve looks a little bit more pallorous in this one, hard to read the cup disc. Some sort of fibrous material coming off of it, maybe some clumped up vitreous. Vessels look okay, maybe superiorly a little bit dilated, inferiorly maybe slightly sclerotic or other way around. MAC, there's that quite a few dot blot hemorrhages, MAs temporally. Yeah.
What do you think about the vessels on the bottom of the screen? If you go like there's that bottom vessel coming over toward the macula, and then the vessel is going inferiorly from that, like on the very bottom of the screen. Those guys. Can you
Very bottom.
Can you see those on your screen?
Oh, okay. So maybe like some sclerotic vessels or ghost vessels there.
Those look kind of ghosty to me.
Dark without pressure, don't they call that?
No.
Have you heard that one?
No, I haven't heard that.
Yeah. What was that
It
one?
could be white without pressure.
Dark without pressure. Where instead of being white, it's kind of in the same area, but it's just darker. Oh, yeah.
Okay.
You call it that.
All right, keep going. Thanks.
Okay, this is OCT of the right eye. Let's see here. Pretty much normal foveal contour. Media on top looks fine, except around the nerve area. You can see some of that vitreous or fibrous material kind of attached there. Doesn't look like it's pulling any traction. Otherwise, looks pretty much grossly normal.
Khaled, I know you're a PGY.
Maybe like some stippling of the inner.
Yeah. Do you know the names of the
inner layers.
four? Can you hear me? Do you know the names
Yeah.
of the 4 white lines if you go from outer to inner, just for a board question? I know you're new, you're like a first year resident for Sec PGY.
Outer to inner?
Yeah.
Yeah, the first one's RPE, then ellipsoid zone, then the interdigitation zone.
What'd you
From
start with
outer to inner.
RPE? So RPE, you're close. First one's RPE, the second one is what'd you say?
Second one, I said like the ellipsoid zone, then the interdigitation zone.
You flip those two.
Okay, interdigitation, then ellipsoid zone.
So you remember, because interdigitation means the RPE is connecting to the photoreceptor. So it's essentially you have 2 RPE layers. You have the back of the RPE and the front of the RPE showed separately. So you've got RPE, interdigitation, ellipsoid, and then what about the light one inside of it? That little guy, right? The one inside interdigitation, go up one. That one.
The
You know what
ELM.
that is? Yeah, extra, good. And the ELM often correlates with vision. So often the two inner ones have to do with vision. Okay, it's a nice scan. We have a little time because I don't think, where's Kevin? He's here. Oh. All right, go ahead. Never mind. You missed that.
So this is OCT of that left eye. There's definitely some opacities in the media, especially on that temporal side, maybe like where the blood is. The inner layers are a little bit more hazy. Again, normal foveal contour is a little bit more flat, but I might be overreading that. But yeah, just like some opacities, or like not opacities, like hyper reflectance in the inner layers temporally.
Okay.
And then maybe a little bit of loss of these interdigitation, myoid. And this might be shadowing, but
Yeah, it could be a little roundy. Yeah, kind of plaquenil-y. It's a little like plaquenil.
Yeah.
Okay. I think this is like an FA of the right eye. This is kind of, I guess, like a later phase. I can't really see the timing in the car, so but it looks like it is
you should get an apartment.
completely filled. Yeah. Yeah, I mean, it's completely filled. I don't see anything abnormal in the right eye here. It looks pretty good. I don't see any defects in the circulation. Maybe like inferiorly, the choroid is slightly a little bit darker, but that might be the lid.
Yeah, that's good. That's perfect. Keep going. So the first one was 1 minute. This one's 4 minutes.
this is 4 minutes.
4 minutes, okay. So late stage, you might have like a tiny bit of leakage, maybe in the nasal macula, parafoveally, off of some of those vessels.
Good.
Then this is at 9 minutes.
Okay. Yeah, it's same. I mean, maybe like on the nasal, the temporal aspect of the nerve head, there's maybe some cilioretinal, or not cilioretinal, like optociliary vessels filling. Not really sure.
All right, just keep going. You're doing well. Kevin is here, so here we go.
Okay, so here we have left eye.
All right, this is the left eye. So I see some, this is probably an early phase, I'm assuming, the arterial phase. I don't see that much filling in the inferior. And then there's a little bit of area of a blockage of some sort superiorly on the, first order arterial.
Good. Keep going. You're doing good.
I'm already
This is at
seeing
20
some
seconds.
leakage in the seconds. Okay, so I'm already seeing some leakage in the nasal, or the temporal aspect, or sorry, excuse me, nasal aspect of the mac. Inferiorly, still having some filling defects there. Okay, it looks like there's some like neovascularization over where those hemorrhages were located on the fundus photo on the temporal macula. Maybe like some slight leakage starting there, but then also there's that leakage kind of inferior to the nerve and temporal to the nerve as well.
The pictures get a little better. There you go. That's a little nicer picture.
Yeah, so just some more leakage, maybe a good size aneurysm inferior to the nerve. Definitely some neovascularization or telangiectasias of some sort on the temporal mac. The temporal area looks like the choroid is hypoperfused, and then inferiorly where we saw some of those sclerotic vessels, there seems to be maybe some areas of neovascularization or telangiectasia formation.
So it's a fluorescein, so you're not really seeing the choroid because the RPE blocks it. So when you see the you said there was hypoperfusion, but what would be the hypoperfusion? Which vascular bed?
Of the, I guess just blood vessel loss. So it's just
that dark. So you see it.
hypofluorescence.
Yeah, there's a dark hypofluorescence there. So it's either got to be blocking or non-perfusion. So that looks like a pretty wide area of non-perfusion. And just to warn you, even though those vessels look funny temporally, and they do look like, wow, that looks like it might be neovascularization, the retinal vessels at the edge of an area of non-perfusion often remodel. So there's a lot of remodeling going on there. So I don't think that's neovascularization temporally. We'll see in the later frames, but that's probably just capillary remodeling at the edge of the non-perfusion.
Capillary dilation.
Yeah, dilation, just,
Compensatory, I think it's compensatory.
right.
The word I want. Dilation.
All right, so keep going. But the area near the nerve does look like it's leaking. So why is that area
Okay, and then
dark?
this area is dark. That's like where the ghost vessels were. So there's really no, there's like a hypofluorescent area there. I'm not sure if, as you said, there's like some sort of blocking going on, if that's due to the RPE changes or RPE destruction there in that area.
It's probably retinal vessels. I think you're just non-perfused. I think you're right about just non-perfusion.
Yeah.
All right.
So there's quite a few of these pictures. There's that 1 minute, then later on at 3 minutes.
Okay. So now I guess is a later phase. Again, there's that little bit of leakage on the inferior to the nerve. It could be honestly that, hey, I remember it on the fundus photo, there was that little hazy component kind of coming off of the nerve, and with the OCT, it might be a vessel actually going into the vitreous, possibly from that area that's filling up with fluorescein. The areas of what I assume to be hypoperfusion on the inferior area of the fluorescein angiography look to be starting to fill up a little bit, but that's just probably late leakage, or not late leakage, excuse me, just late phase, just general fluorescence.
And just because we're used to, sir, we always call it non-perfusion. Hypoperfusion actually is probably more accurate, but we usually call it non-perfusion.
There's that 7 minutes. There's quite a few of these photos.
I can see little white dots near where maybe there's some leakage there.
Yeah, we usually do sweeps, just trying to find where the non-perfusion is. It can be helpful for treatment. So when you go back to the fluorescein, was the fovea involved with the non-perfusion? Can you tell? It helps a little bit like there, yeah. So do you see a fovea? Is it hitting the foveolae vascular zone or no?
I think it's kind of sparing it. I think it's maybe like perifovea is involved.
It's close. I thought it might be too, but I think it actually is getting. I think I can't quite see a foveolae vascular. Can you draw, Grant? Can you point where the foveolae vascular zone probably should be? You sort of look at the truncate, right? Go down, left, down a little, left a little, right? Probably right around there. You see that vessel kind of ends, probably a little more to the right, down a little, right there, maybe a little left. Yeah, right there. That's probably where it should be, because you can see the vessels are sort of pointing in that way. So I think that is getting clipped by the non-perfusion. So the visual prognosis in this patient is not very good because of that. It helps with the vision. All right, Keith, so go ahead. You got to do your differential and all that.
Yeah, I think top of my differential, just based on the history and the findings there of all that non-perfusion ghost vessels, would just be like a either a severe to rather a very severe to PDR, and with that kind of fibrous area on top of the nerve, maybe it's forming a PV, or starting to form a PVR that hasn't really tugged on the retina yet. Those would
So
be
if you
my
have to
main
do
two.
if you want to do 3 things in your differential, you can put PDR as one, but you have to come up with another 2 things that cause non-perfusion, especially wedge-shaped non-perfusion.
I mean, it's unlikely, but it could be like MacTel or something like that. Maybe a type 1.
And then we did the sweep. Go back to the fluorescein, Grant, would you? So what area? Can you see the area? Go back one more, maybe. Go where the macular, there. So does it look like it's diffuse or just in one area? If you can find one vascular distribution, then sometimes you can pin it on the vessel.
Yeah, like a BRAO or something.
Yeah, BRAO, or what other branch vascular occlusion could you have?
Remember the fundus photo?
You could also have like which one? The fundus
No.
photo?
Yeah.
I mean, you
hemorrhage.
could have like a cilioretinal artery occlusion, if that's the case, if it's just affecting that central area there.
Yeah, we're trying to nudge you toward vein occlusion.
Oh, vein. Okay, yeah. BRVO then.
You could have a vein occlusion. It's interesting. Artery occlusions don't, for some reason or another, tend to cause non-perfusion and neovascularization, which is weird. But anyway, go ahead.
Yeah, so good. So we touched on a few of these with the vein occlusions, with the sort of sectoral blood and thunder-like appearance. Then there's also ocular ischemic syndrome that causes similar presentation. And then some of these other causes, hypertensive retinopathy, hyperviscosity retinopathy, other things that can cause focal non-perfusion in the retina. And then other things like radiation retinopathy, MACTEL, which Colin mentioned, and then some forms of AMD with neovascularization. So this patient had PRP because of the neovascularization. Her vision did not improve and it remained 2160. There's a few images 1 and 3 months afterwards. So this one's showing some PRP. So I'll be discussing branch retinal vein occlusion. So prevalence is anywhere from 0.5% to 2%. It's most common, it's the second most common retinal vasculopathy after diabetic retinopathy. It appears to be most common in Hispanics and least common in people of white or Caucasian ancestry. There's no obvious sex predilection, and 5 to 10 of cases can be bilateral. The most common location is superotemporal, and we'll talk about why that might be a little bit later. So risk factors, so increasing age, hyperlipidemia, which our patient had, hypertension or increased pulse pressure, ocular hypertension, and then also ocular perfusion, which is a function of both hypertension and ocular ocular pressure. So that kind of makes sense. Glaucoma, also related to elevated pressure. If patients have AV nicking or focal vessel narrowing, they're at increased risk. And then if they have elevated BMI, and BMI seems to be an especially strong risk factor in patients under age 50, which our patient was under age 50, but I don't know if Dr. Cohen remembers if she had an elevated BMI or not.
I don't think so.
No. Okay. So, and then other causes like thrombophilia, so hyperviscosity type thing. So hyperhomocysteemia and anticardiolipin are the only two things that have good evidence behind them. And then there's a whole bunch of other hyperviscosity causes that don't really have strong evidence, but there's a good theoretical basis. So factor V Leiden, the MTHFR mutation, protein CNS deficiency, etc. And then I'm just including this because I had an optional questions on it, and they mentioned it in a few articles that notably diabetes does not appear to be a risk factor for branch retinal vein occlusions, but it is a risk factor for central retinal vein occlusions. That sounds like just the kind of useless information that's tested on OCAP.
Tested.
I don't know.
It never made
sense.
sense.
That doesn't
And
make
it
sense.
never made sense.
Yeah, it's
It doesn't
tested,
make
yeah.
sense. Like theoretically.
Probably if you did a big enough survey, it would be true. It's probably some low
larger
paper.
lumen, so why
Yeah.
would you include that and not a branch?
Right.
Well,
All right, go ahead, you're doing well.
Yeah, kind of a strange.
With the fact, not with your prejudice. Exactly.
I have a lot of prejudice there too.
So pathogenesis, it's probably multifactorial and it's not exactly defined. I think the leading theory is just a mechanical compression. The artery and or the arterial and the venule have a common adventitial sheath when they cross. And so you can see with arteriosclerosis, just progressive venule compression as that artery becomes more and more sclerotic, and that causes the venule to become tortuous, and the compression combined with the tortuosity leads to turbulent blood flow and endothelial damage, and then kind of hitting several of the things in Virchow's triad, so that can lead to an occlusion of the vein. And then I mentioned earlier that the most common location of BRVOs is superotemporal, and that's at least theoretically because there's a larger number of AV crossings in the superotemporal quadrant. There's also hypercoagulation causes and blood vessel wall degeneration mentioned. Loss of visual acuity is primarily from macular edema, and there's multiple cytokines that are involved in macular edema, VEGF, which we all know, and then there's also IL-6, IL-8, and monocyte chemoattractant protein 1. So the diagnosis and classification. So diagnosis is clinical, but OCT and FA are useful for management and prognostication purposes. So there's several different classifications of retinal vein occlusions. There's central retinal vein occlusion.
Code gray, 5K3. Code gray, 5 kilo 3.
Central retinal vein occlusions, hemiretinal vein occlusions, and then branch retinal vein occlusions. Among the branch retinal vein occlusions, there's major, which involves an occlusion of a vein that drains one of 4 quadrants. And in these cases, there's much higher amounts of VEGF and cytokines produced. And because of that, the anti-VEGF agents aren't quite as effective. And so these patients tend to need more treatments to resolve their edema. And they often end up with worse outcomes than non-major BRVOs. And then you have a macular BRVO, which is an occlusion of the venule within the macula, which also leads to worse outcomes. And then an inflammatory branch retinal vein occlusion is related to co-occurring vasculitis, and you'll see multiple peripheral vein occlusions in different stages. So just like our patient, she had a sudden painless vision loss. Patients can have visual field defect, which starts relative and can become an absolute scotoma. And then they may have an increase of floaters from associated vitreous hemorrhage. On fundus exam, you'll see that classic blood and thunder sectorally, but then you can also see things related to edema like exudates and other vascular sequelae. Uncommonly, patients can have their initial presentation related to neovascularization, and that can involve the anterior segment, including the iris and the angle as well. So evaluation just involves, of course, a complete history and exam. Gonioscopy is a good idea to look for neovascularization of the angle, OCT and FA, and then just like a systemic workup to look for underlying causes and risk factors. So just generally speaking, some basic labs, including a lipid panel, is probably enough for most patients. But in a patient younger than 50, when appropriate, you can consider infectious, inflammatory, or in a hypercoagulable workup if they don't have any other risk factors. So OCT is a useful imaging modality. Oftentimes in FA, this patient had kind of an old vein occlusion, so she didn't have as many intraretinal hemorrhages, but that can negatively affect the quality of an FA. OCT isn't as affected by those hemorrhages. So you can easily see the macular edema associated with it, which would direct treatment. And then we noted earlier that our patient had disruption of her ellipsoid zone, and that's a poor prognostic indicator for visual acuity. She ended up not having much, if any, visual recovery. That's consistent there. Fluorescein angiography is useful because it characterizes the extent of non-perfusion, ischemia, edema, and leakage. So we saw in our FA findings that There was delayed filling of the vein on the FA. We saw capillary non-perfusion. I don't know if we really noted blockage from the intraretinal hemorrhages because there weren't too many of those. And then our patient didn't have macular edema by the time we saw her, but she might have had some prior. So management, so there's a number of things that can be done depending on if there's macular edema, focal areas of ischemia, and neovascularization. Laser photocoagulation is a little bit of an older modality these days, and also steroids as well. And then there's anti-VEGF, which is sort of the mainstay in BRVO with macular edema. And then if there's a non-clearing vitreous hemorrhage, a vitrectomy. Then there's some of these older treatments that are sort of falling out of favor, sheathotomy and isovolemic hemo dilution, which I was not so familiar with. So I'll talk about those a little bit as well. So laser photocoagulation was formerly the gold standard before anti-VEGF came along. And basically the idea was to destroy capillary beds near the edema, reducing the arterial supply and favoring drainage. There's grid photocoagulation, which was used in patients who had no improvement in their visual acuity for at least 3 months. And then an FA can delineate where the non-perfusion was. Then you can follow it with a repeat treatment later. And then there's scatter laser photocoagulation to prevent vitreous hemorrhage if there's greater than 5 disc diameters of non-perfusion with neovascularization. Steroids was another more first-line treatment modality before anti-VEGF came along. Of course, there's side effects associated with it, including cataracts and IOP elevation. Typically, triamcinolone was used, and when compared with laser treatment, it compared well up to about 3 years, and then laser was better, so it was generally a second line or adjunct to laser. It can still be used as an adjunct to anti-VEGF. Then, of course, we have Ozurdex these days, which is a dexamethasone intravitreal implant. Importantly, Ozurdex was compared to laser, but it hasn't been compared to anti-VEGF. So anti-VEGF, sort of the mainstay of treatment today, is useful with BRVO with macular edema. It can be followed by focal laser to improve durability of effect, or to sort of as like a rescue technique. There's the schedule of injections by all of these studies. So the BRVO study, which used ranibizumab, the CRUISE study, which was also with ranibizumab, the Vibrant trial, which was with aflibercept. They did monthly injections for 6 months and then tapered as appropriate up to a year. And then the Horizon trial, which was again with ranibizumab, just followed these patients and saw that there was success with just a PRN after the first 12 months. So of course, we're all familiar with Avastin, which is bevacizumab, which is a full-length antibody for VEGF. And then ranibizumab is an antibody fragment that binds VEGF-A with higher affinity than Avastin. And then aflibercept or Eylea, which is a recombinant protein with VEGF receptor 1 and 2 domains fused to an FC portion of IgG1. It has the strongest affinity for VEGF-A, and it also has affinity for VEGF-B placental growth factor. So sheathotomy is where the surgeon can go in and surgically cut the adventitial sheath that's around the artery and the vein at the AV crossing in order to alleviate the pressure that's on the vein. But the literature is sort of inconclusive on this, and because it's a surgical procedure with significant risk, it's not really in favor nowadays. And then
that was done before anti-VEGFs, and it really didn't work. It's easier to cut the vein than the sheet. With all of our instruments.
Isovolemic hemodilution, I really wasn't familiar with this at all, but really it's a procedure that's done in surgeries where there's a lot of blood loss in order to reduce the need for blood transfusion. And so basically blood is collected before the procedure and their volume is replaced with this hydroxyethyl starch. And then the patient's blood is returned at the end of the procedure. And studies have shown that there's small improvement, but there's significant complications, and so it's not really used, especially with VEGF nowadays.
Like something
It's a good research.
I gag a sheet. I don't know.
You're doing really well. Interesting.
So prognosis for BRVOs, about 50 to 60% of patients end up with a final visual acuity of 20/40 or better. So there's kind of a decent prognosis for about half of patients. But poor prognostic indicators include chronic macular edema if they've had a major or macular BRVO, if they have neovascularization resulting in vitreous hemorrhage, or if their initial visual acuity is poor. Those are all poor prognostic indicators. And then BRVO in one eye increases the risk of having a BRVO in the fellow eye to 7 to 10%. And that's all I got.
That was nice. That was very well researched.
Good call, real, very quick. Did she have fit heme?
A little bit, not much. No, I don't think I think it's just neovascularization.
So what was all the hypercellularity on the OCT? Or-
I think it was a little, I think it was like subclinical hemorrhage.
Okay.
Had to be.
So did you send her for a workup?
No, so I don't work up branch veins because I just don't think it's. Do you want to, however you want to wait for next one?
Yeah, okay.
Are you gonna be here next month?
Yeah.
Good.
A little short.
Is
Yeah, yeah.
it short?